Dear students, a very warm welcome to you to e-learning course Infection Prevention and Control, a primer. This is a collaborative course which is being offered by University of Hyderabad and COL SIMCA along with Infection Control Academy of India. This is going to be the first of 8 modules which are going to be the course, and this particular module is going to deal with infection prevention and control as science and its role in healthcare and community. This module is structured in a way so that you can get the maximum benefit. In this module, we have the learning objectives of the module, infection prevention definition, outlining the history of infection prevention and control, goals of infection prevention and control programs, IPC program, and positive impact it can make on healthcare organization, and of course then looking at what is the follow-up learning you all had to do in order to get the maximum benefit of this module and the course. First, let us look at what is learning objective of this module. The learners will be guided and empowered to comprehend definition of infection prevention and control, historical perspectives, goals of infection prevention and control implementation, and the positive impact envisaged. After completing this module, we expect the following competency. 1. To define IPC as science, understand the history of infection prevention and control, and role of those pioneers of infection prevention and control like Nightingale, Semmelweis, and other professionals who have influenced the trajectory of infection prevention and control as science. Identify infection prevention and control goals and their contribution to safer healthcare, and then finally institute contextually relevant and appropriate guidelines in your own settings. Now look at the theme of the day. What is infection prevention and control? Infection prevention and control is a scientific approach and practical solution designed to prevent harm caused by infection to patients and healthcare workers within healthcare institutions and situations. It is grounded on several subjects like infectious diseases, epidemiology, social science, and health system strengthening. It is an essential part of the infrastructure of healthcare, especially patient safety programs. Prevention and control of healthcare associated infections is an important focus at the local, national, and international level. Infection prevention and control is an issue of health and safety, a necessary component of safe, high quality patient care, and it is essential for the well-being of the patient and staff. As already mentioned, IPC occupies a unique position in the field of patient safety, and it is relevant to healthcare workers and patients at every single healthcare encounter. The discipline is concerned with preventing nosocomial or healthcare associated infections, and usually infection prevention and control is also talked about as a subdiscipline of epidemiology. It is all the public health activities mainly practiced within a healthcare delivery system, and infection prevention and control focuses especially on evidence-based practices and procedures that can prevent or reduce the risk of transmission of microorganisms to healthcare providers, clients, patients, residents, and visitors within the healthcare institutions and situations. Now let us look at why is that infection prevention and control is so important for healthcare system. Because infections are a leading cause of morbidity and mortality within the healthcare settings. Before advancements in infection prevention and control, only condition that brought patients near death warranted the risk of surgical intervention. If patient survived the operation, infection was nearly inevitable and death occurred by overwhelming sepsis. In the late 19th century, with the development of germ theory by Louis Pasteur and its subsequent application to surgical sterility by Joseph Lister, surgeons all over the world were able to operate with a substantially reduced risk of infection. Infection, as we know, is a major cause of human suffering. Even relatively minor infection can become more serious, leading to major infections and can, in some cases, lead to patient death. In addition to patient suffering, infection causes distress to family, to friends, and all those who are surrounding the patients. In addition to all that what is said earlier, the acquisition of occupationally acquired infections may pose a risk to healthcare providers. In order to protect patients and staff and to reduce the costs of healthcare associated infections, it is necessary to prevent infections before they occur. Infections, as we all know, can cause prolonged hospital stays, which has an impact on costs and out-of-pocket expenses which are going to be incurred by the patients, making their lives even more difficult. Now, let us look at the history of infection prevention and control. If we had to trace the early efforts at wound prophylaxis, we can trace them to almost like pre-1800. During the period from 1800 to 1940, we had several healthcare professionals like Nightingale, Semmelweis, Lister, Pasteur, and other professionals who have made a significant contribution in understanding the infection, the transmission of infection, and certain procedures and processes and the products which can help us to prevent the infections within the healthcare. If we look at the 1940 to 1960, we can call it as antibiotic era, because during this period, as we all know, the first ever antibiotic penicillin was invented. But at the same time, within no time, during the 1950s itself, epidemic penicillin resistant Staph aureus infections, especially in hospital nurseries, captured the public attention and highlighted the importance of techniques to prevent healthcare associated infections. Now, earlier times they used to be called as hospital acquired infections. In USA, the landmark studies were conducted in 1970s, which has triggered the rapid evolution of infection prevention and control in the clinical setting. Ongoing surveillance of healthcare associated infections was initiated and stimulated further when infection prevention and control and surveillance activities were mandated by Joint Commission for the Accreditation of Healthcare Organization, or popularly known as JCI. Then if you look at 1980s, there is the time when the whole world has got a new scare which was called as HIV or AIDS. And during this period, the world has observed a very rapid change in terms of resistance to antibiotics emerging in the bacteria. A first national study of the prevalence of healthcare associated infections in the United Kingdom was conducted in 1980, and Belgium performed a prevalence study in 1984. At the end of 1990s, most countries in Western Europe had guidelines for prevention of healthcare associated infections. And if you look at again 1980s, there were studies which have come into the picture about the efficacy of nosocomial infection control and demonstrated the surveillance for HIs and IPC practices that included trained professionals were effective in reducing healthcare associated infections. The USA Center for Disease Control began a national nosocomial infection surveillance system to provide a mechanism for reporting healthcare associated infections. As a result, an important role developed for hospital epidemiologists and infection control practitioners. Then further on, if you look at 1990s, several blood-borne pathogens were observed and several prophylactic measures were instituted. And during 2000s, the world has come in brush with several pandemics, and the patient safety subject has come into the vogue. So if you broadly look at the recent history post 2000, including low resource settings, everybody is trying to set up their own national guidelines and also institute the mechanism in order to prevent healthcare associated infections. If you look at the Indian scenario, although we do not have yet a foolproof guideline at a national level, but our NCDC has recently released a draft program to prevent healthcare associated infections, and this is very rapidly becoming a practice within the healthcare system in India also to go for the guidelines which had been prescribed both by WHO, CDC and NCDC. Now let us look at some of those professionals, healthcare professionals, who have made a very significant contribution towards infection prevention and control. Florence Nightingale is one of such persons, and she is mostly referred as the first infection prevention and control champion. And Nightingale had firm belief in preventive medicine that led to an established standard of formalized cleanliness and sanitation in hospitals and military. If you look at Florence Nightingale, who was born in 1820, has demonstrated the effectiveness of close collaboration between infection control nurses and hospital epidemiologists. She once stated that it may seem a strange principle to enunciate at the very first requirement in a hospital that it should do the sick no harm. I think I would repeat once again. She has said that hospital should do the sick no harm. She observed that open windows interfered with the ventilation of hospital wards and allowed air from the wards to pass into corridors. Nightingale believed that respiratory secretions were potentially dangerous, especially among the sick, and the sick should be isolated. Her research into hospital sanitary problems made her a firm believer in pure air, pure water, efficient drainage, cleanliness and light. So we can with all firmness say that Florence Nightingale is the first infection control nurse in the world. Now let us look at another pioneer in infection prevention and control, Ignaz Semmelweis. He is the person, a doctor from Vienna, who has demonstrated that the routine hand washing could prevent the spread of fever after childbirth, called as puerperal fever. As we all know that Dr. Semmelweis was a Hungarian obstetrician who has practiced in Vienna, and he is credited with first discovering the healthcare providers could transmit disease, as he described the mode of transmission of puerperal fever. When he joined the Vienna hospital, the death rate in that hospital was 5 times higher for mothers who delivered in the hospital than for mothers who delivered at home. He also witnessed a pathologist die of sepsis after sustaining a scalpel wound while performing an autopsy on a patient with puerperal sepsis. He noted that the pathologist's clinical illness mimicked that of women with puerperal sepsis and identified that not only a scalpel but also physician's hands contaminated after an autopsy could transmit contaminated material or microorganisms to mother in labor. Semmelweis' analysis has revealed that medical students who were responsible for deliveries in Division 1 often performed autopsies before assisting in deliveries, while midwives who worked in Division 2 did not. Based on this information and the data, he has introduced chlorinated lime hand washing into the clinical staff by obstetricians and medical students. This has drastically improved the rates of maternal mortality or the decline in maternal mortality. As usual, all the good ideas and the pioneering ideas, his idea of this hand washing as a preventive measure was ignored and ridiculed by his colleagues. When Koch's postulates were published in 1890, the germ theory of disease and Semmelweis theory of transmission from patient to patient were considered plausible. And then he propounded a theory that disinfecting hands could prevent transmission of infection from a deceased cadaver to a pregnant patient. So, as been earlier told, the use of hand hygiene as a measure has resulted in a dramatic outcome. Deaths on the maternity ward fell fivefold. Now, let us go to another person who had significantly contributed again to infection prevention and control. His name is Joseph Lister. He was a doctor in England who was troubled by high mortality rates from post-surgical sepsis. Professor Lister, who was a professor of surgery at Glasgow, he is credited with the beginnings of sterilization in the operation theatre. Before surgery, he sprayed the operating rooms with carbolic acid because he thought that the infections were caused by dust particles in the air. Initially, he was ignored by most of his colleagues and even the students. And then in 1867, he published his paper on antisepsis, stating that all the local inflammatory mischief and general febrile disturbance which follows severe injuries are due to the irritating and poisoning influence of decomposing blood and sloughs. That is when he started applying carbolic acid to compound fracture wounds, which has resulted in healing and averting the amputations, and by this procedure reducing the mortality rate from 45% to 15%. Now, let us look at infection prevention and control programs. When they started, how they started, and what is the current status of these infection prevention and control programs. The earliest formal programs were in 1950s. It has begun as an effort to address issues like staphylococcal epidemics. During the past 20 years or so, there have been major advances in the field of infection prevention and control. The focus has moved from identifying the risks and prevention techniques for various types of healthcare associated infections, including pneumonia, bloodstream infections, urinary tract infections, surgical site infections, etc. All these infections are going to be detailedly be talked about in further modules, and my colleagues are going to give much more deeper information about them. Hospital acquired infections or healthcare associated infections are being caused by pathogens with greater resistance to antimicrobials. There is a major focus on preventing spread of these microbes through antimicrobial stewardship and proven infection prevention and control practices. If you look at the surveillance of hospital infections was instituted, and policies and procedures were developed in almost all the countries now, including those in low resource settings. We talked about all major healthcare associated infections. Now, World Health Organization states that urinary tract infection is the most frequent healthcare associated infections in high income countries, and surgical site infections in settings with limited resources. Of course, as we all know that statistics in low resource countries are often non-standardized or incomplete. But nevertheless, when it comes to our own scenario within India, these assumptions what had been made and the data which has been projected in so-called developed countries there might be a little gap, but the reality is that healthcare associated infections is equally a problem in India too. 30% of the patients who acquire infections within the healthcare system, it usually happens in intensive care units. And the frequency of ICU acquired infections in low and middle income countries is several fold higher than in higher income countries. Now, let us look at what are the goals of infection prevention and control. To prevent the spread of infections from patient to patient, patient to healthcare provider, healthcare providers to patients, healthcare providers to healthcare providers and to visitors, and subsequently or consequently, the goal is to protect patients from healthcare associated infections, resulting in improved survival rates, reduced morbidity associated with the infections, shorter length of hospital stay, and quicker return to good health. Let us look at what are the functions of infection prevention and control. In my opinion, the first and foremost, the function of infection prevention and control is to implement evidence-based practice, standards, and guidelines through setting specific policies and procedures, and to intervene directly to prevent infections, to provide effective occupational health programs, to educate and train healthcare workers, patients, and non-medical caregivers, to provide communication of infection-related issues and relevant practices to leaders and staff to facilitate improvements, to evaluate the program and improve it as necessary. The fundamental function or the functions are applicable, what all we talked about now are applicable to all settings where healthcare is being provided. It is regardless of the structure or hierarchy of the healthcare system, and the major responsibilities would include surveillance, continuous quality improvement, consultation, committee involvement, outbreak and isolation management, regulatory compliance, and of course the education and awareness. Let us look at the IPC practice of today. What are the major components of it? The major components are surveillance, outbreak investigations, prevention through practices guidelines like hand hygiene, use of barriers, especially the personal protective equipment, isolation precautions, construction, renovation, sterilization, disinfection, antibiotic resistance, blood-borne pathogens, food, water, air safety, cleaning, etc., etc. I would like to mention here that from all the mentioned practices, one big impact which can be immediately seen in healthcare settings is hand hygiene. Hand hygiene could contribute in a very big way to the prevention of infections within the hospitals. When we are saying about the policies and procedures, they are typically written, approved by some group and shared with pertinent staff. And usually these policies may include all that what we talked about, including antibiotic use, education, occupational health, and then definitely the audits which had to be conducted in order to see the effectiveness of the practices within the given healthcare institution. So, after implementing all those infection prevention control guidelines and also getting those good practices into healthcare institution, what is the impact it can make? I think, in my opinion, the first and foremost is going to be the reduction in infection. That means the reduction in the human suffering. And of course, it is going to significantly contribute towards improving the survival rates, and it can reduce the morbidity associated with infections, which consequently is going to lead into shorter length of hospital stay, a quick return to good health, and definitely reducing the healthcare costs. It is not only about actually the costs related to these particular infections which are associated with healthcare. But a good infection prevention and control practice can have a very good impact on reducing the antimicrobial resistance. And a reduced antimicrobial resistance could have a significant impact not only at a healthcare level, but even at community level, which automatically is going to make the communities healthier. And hence, following the infection prevention and control guidelines and putting those guidelines into practice is very essential to make our healthcare system a very safe and very effective and quality oriented. So now let us look at what is that you need to follow up in terms of learning so that you can get the maximum benefit out of the module which has been presented today. You are expected to review the handout which is provided for this module and then read additional material which has been mentioned as reference material, and then consider discussing the topic among the participants. I am sure you would find within this module a group where you can interact online with your other fellow students. And we will also actually encourage you to join infection prevention control organizations for network and also continuous education. One of such organizations which is very popular in India is Infection Control Academy, and you can become not only an active member but also a contributor to the improved IPC system in India. You can also actively participate in the discussion forums, and don't forget to complete your assessment within the stipulated time so that you can gain your certificate of completion. Thank you. Thank you for your patient hearing, and I am sure this particular module is going to help you in understanding infection prevention and control as a subject, as a science. Thank you very much and have a great day ahead.